You want to help every family that calls, but your schedule's full and the need keeps growing. What can you do when you can't take another patient? In this episode, we'll talk about how to manage referrals, support other providers, and build systems that make a difference even when you have to say no.
I'm Dr. Josh Fader, the editor-in-chief of the Carlat Child Psychiatry Report and co-author of the Child Medication Fact Book for Psychiatric Practice, 2nd edition 2023, and our other book, Prescribing Psychotropics.
And I'm Mara Goverman, a licensed clinical social worker in Southern California with a private practice and an avid reader of the Carlat Psychiatry Reports. Today, we're talking about something that almost every mental health provider in child and adolescent care runs into: too many referrals and not enough capacity.
Right now, the number of trained child psychiatrists in the U.S. sits around 8,300. Meanwhile, more than 15 million kids and teens meet criteria for a psychiatric diagnosis. That's about 1 in 5.
And the gaps hit hardest in rural areas and communities with fewer resources. It raises a question providers face constantly. Which referrals do you take, and what do you do with the ones you can't?
Yeah, so let's start there. One of the first things clinicians can do is clarify their scope, what kinds of patients they're set up to see, what treatments they offer, and what their capacity looks like for new referrals. That kind of clarity can shape what gets accepted and what's redirected.
And that redirection matters. Families are often left hanging when they hear, "I'm not accepting new patients." A better approach is to build a plan. What do you say? Where do you point them to? What resources can you share?
Even if you can't take them yourself, you can give them a next step. That might be a referral list, ideally at least 3 names, so it doesn't feel like a medical recommendation that you're liable for if something doesn't go well. Or it might be crisis numbers for more urgent cases.
And that list, it helps to include a mix. You might include providers who take insurance, some who offer specialty care, and others who handle more general needs. It could include therapists, NPs, developmental pediatricians, and PCPs with interest in mental health.
Some clinicians keep a voicemail message or auto reply that gives families information up front, whether they're taking new patients and where to turn if they're not. That reduces the back and forth and gives families quicker direction.
It's also okay to say, "This is out of my scope," especially if the referral seems routine. A child with uncomplicated ADHD, anxiety, or depression might not need a psychiatrist. You can refer them to a PCP, a therapist, or a psychologist for testing.
Let's talk about how to make those referrals smoother. What helps you trust a handoff? And it's really important because when we think about our training, ADHD, anxiety, depression, those can be bread and butter in some ways. And if they're mishandled by somebody who's not a psychiatrist, then they may end up with us later. But you're right, Mara, we just can't take all of those referrals. I get so many referrals every day, and you get into the habit of saying, "I'm so sorry." It's not easy. It really isn't. I mean, for my own practice, I've had a system for a number of years where I have a voicemail that says, "Please go to my website and, give me the information and, do that through my contact button." And that, when people actually do that, is really helpful because then I can look at what their, difficulty is. And then, like we've talked about, I have a list of referrals. Sometimes it's for psychological testing. Sometimes it's for therapy. And a lot of times it's for a colleague psychiatrist who might be in better place to take those referrals.
So what you're also suggesting is that you start building and updating your referral list the day you open your door.
And you know what? I do this and I tell colleagues to do it. But when we put this article in Carlat, what was it, last summer or something, I got a lot of pushback from my review board saying, clinicians don't have time to build and cultivate lists and be responding to everybody who calls. And I respect that. Not everybody's going to be able to do that. It works for me. but maybe something different works for other people.
Another thing providers can do is develop a basic referral letter template, something you can personalize with diagnosis, what treatments have been tried, what worked, and what you'd recommend moving forward. That's helpful for families and receiving providers.
I do that a lot. So I'm in a phase of my career where I'm referring a lot of people out now who I've been seeing for a number of years. And a lot of them are pretty stable, and they could be seeing a primary care doctor, nurse practitioner, or somebody else to just continue. And I have a standard format for a relatively brief letter. That's what gets read anyway. If you write a long report, a lot of times people don't read it. And I just go through and I have the name and the birth date and how long I've been seeing them and the diagnoses that we've been working on and the things that seem to have worked for them. Biopsychosocial, all the things that have been working, a little bit about the course of care. The whole thing's done in a couple paragraphs, and it's really helpful for the receiving doc. And for some people, I'm going to make it a warm handoff and call that receiving person if they have somebody. If you're in a setting where a program is ending, like an IOP or a schooling service, which has a time frame and then people complete it and then they go off to something else, you probably need a plan for transitioning patients. And that's another spot where a summary and clear recommendations help the next provider to pick up the thread. So while we're talking about not taking patients who might be, in a way, too simple for us to be taking on, I mean, we really should be taking the more complex kids, it is important to have a caseload of people who you're able to see over time, watch them develop, maybe do therapy with them. And as they grow, you get to see them do new things and take on the world. And so, that's one of the joys of practice. And while we can't burn ourselves out by taking every new referral of every child, and we can't keep every patient who we've been seeing because they probably should go to a different provider, it's part of the joy of practice and preventing burnout to have a caseload of families who you follow over the years. Thoughts, Mara?
You're wearing the hat of a practitioner who doesn't take insurance, and I would imagine that there are different challenges for many of our listeners who are under managed care or insurance plans and might not have that availability. But having worked with you for so many years and having the privilege of following many families, you also have to stay in your lane. If your area of expertise and comfort is in a particular range, you have to do a lot of self-reflection and check in to be sure that your standard of care is at its best so that you are serving your clients and giving them what they need to get to the next level.
Let me pick up on that just for a second, because it does happen that people developmentally move beyond where I would be continuing to care for them. So, for instance, I'm not currently taking couples therapy, right? So I might be doing therapy with someone, they get married. Now they're having couples difficulties. Am I going to turn it into a couples therapy? At this stage, no. I'm going to refer them to somebody else to do that work. It's a really good point.
Speaking of transitions, let's talk about stepping patients down. Some will do well enough that they no longer need specialty care. Others might ask to reduce visits for cost or convenience. And one approach is to ease up on appointment frequency, stretch out visits and see how they do. If they stay stable, consider transitioning to a primary care provider or behavioral health nurse practitioner or somebody like that. For some patients, you might also check in once a year or be available for consults. And I do that often. People are done, they're done with me, but they can come back and say hi if something kind of goes south on them. The primary care person who's prescribing can give me a call, something like that. We just got a call before we started recording today from a primary care doc who's doing the medications now. The person consults me periodically. They just had a change in their life. They gave me the heads up that I might be needed for a consult. So, the word that keeps coming up is continuing to assess stability, especially when you're talking about patients who come out of an IOP and they're in a euphoric state. Those tend to be the most dangerous times. So you have to be very careful about assessment and appointment frequency at the beginning.
Right. So people come out of programs and then they kind of fall through the cracks.
Yep.
We don't want to see that happening. And I've seen that so often.
And it helps to be upfront with families, or at least be as honest as you can. They may want to stay in specialty care indefinitely, especially if they waited a long time to get there. It's okay to say your care is going well and you may not need this level of specialty care support anymore.
So this is your specialty. Mara's got a busy practice, busier than she can stand sometimes, and she'll often be helping refer people, being a little bit of the, okay, it's time to do something different, right?
Well, there's that ethical dilemma of dependency, independence, and how do you weigh allowing people to stumble and try to figure that out without supporting? Not easy for me. Let's also discuss supporting non-psychiatrist prescribers. Pediatricians sometimes feel uneasy managing psych meds. They may worry about what happens if the child worsens or a new symptom shows up.
And clinicians can normalize that. You might say, here's what I'd monitor, like often abnormal involuntary movements, lipids, hemoglobin A1C,
BP.
Stuff like that, blood pressure. Or offer a one-time consult, right? Some primary care providers get extra training through programs like the REACH Institute or local behavioral health collaboratives.
And organizations like the American Academy of Pediatrics provide step-by-step guidance for conditions like depression, anxiety, and ADHD. Many states also have psychiatric consultation programs for primary care.
Bottom line, no one provider can meet all the demand, but you can create systems that help you respond consistently, refer effectively, and support care across different levels of training.
And if those systems aren't in place yet, start small. Build a referral list, update your voicemail, create a village. Write one good handoff letter. Over time, those small moves make your practice more sustainable.
And they help build capacity across the whole community, and that's the long game, right? So, the idea here is we're trying to keep ourselves from getting burned out and at the same time provide as much care to as many people using our specialty skills where they're needed and not where they're not. That doesn't mean that you never take patients who are fun and easy follow-ups. Not everything can be, very, very complex and overwhelming. But you do need to titrate that if you're really going to do the most good for the most people in your career and preserve yourself at the same time. Dr. Charmi Patel-Rao's interview in our April, May, June 2024 newsletter is the inspiration for this podcast, and it contains additional resources on how to refer a patient. If you found this episode valuable, please share it with others who need to hear this message.
Everything from Carlat Publishing is independently researched and produced. There is no funding from the pharmaceutical industry.
Yes, the newsletters and books we produce depend entirely on reader support. There are no ads, and our authors do not receive industry funding. That helps us to bring you unbiased information that you can trust.
Remember, we are all in this together. Stay informed, stay engaged, and let's continue the conversation.
Thanks for tuning in to the Carlat Psychiatry Podcast. Until next time, take care and stay safe.